ओके सो गाइस हाउ यू ऑल डूइंग। जैसे कि हम लोग मेडिसिन और माइक्रोबायोलॉजी के लेक्चर्स तो बुक से वन बाय वन चैप्टर वाइज कवर कर रहे हैं। आई थॉट व्हाई नॉट कवर अ पार्ट ऑफ ऑब्स एंड गायनी एज वेल। सो दीज आर नॉट बुकिश और word to word lectures. Rather, these are kind of orientation lectures. A series of maybe 5-6 lectures will be there in which we will be covering the highly important topics of obstetrics as well as gynecology. So I've made a list of the important topics which I'll show you. In this video, we'll be covering 4 or 5 important topics of obstetrics, and in subsequent 2 or 3 videos, we'll be completing the obstetrics part, and then we'll shift to the 9-10 important topics of gynecology as well. Okay, so let's start with the very first topic. Let us first see the list of all the important topics of obstetrics. Okay, so these are some of the important topics. First one being the anatomy of female reproductive organs, the fundamentals of reproduction, the placenta and fetal membranes, the fetus, which includes the physiology and circulation of the fetus, the diagnosis of pregnancy, antenatal care, preconceptual counseling, antenatal history and examination, hyperemesis gravidarum, medical disorders in pregnancy, anemia in pregnancy, hypertensive disorders in pregnancy, diabetes in pregnancy, heart diseases and HIV in pregnancy. We'll also be covering some short parts like preterm labor, medical termination of pregnancy along with abortion also, and we'll be also covering the postpartum hemorrhage in this OBS part. Okay, so let us start with the very first topic, which is about the anatomy of female reproductive organs. We are not including the diagrams. You are much well aware of the diagrams and you can always refer to them in your textbooks. Okay, we are basically just revising the concepts in a quick go. Okay, so the external genitalia is there, vulva. It includes mons pubis, which is a fatty tissue over the pubic bone. There are labia majora and minoras. These are protective skin folds. There is clitoris, which is an erectile tissue which is homologous to penis. And there is vestibule, which contains urethral and vaginal openings. And Bartholin glands are there. They are at 5 and 7 o'clock positions of the vaginal introitus, and these secrete the mucus, which makes the vaginal, the female reproductive pathway slippery. Okay, in the internal genitalia part, there are vagina. Vagina is a fibromuscular canal, 7 to 10 centimeters. It extends from vulva to the cervix, and it is lined by non-keratinized stratified squamous epithelium, and also there are present dordaline bacilli, which are lactic acid fermenters, and they have rugae to allow for expansion, example during childbirth. So it is a folded structure. At the time of childbirth, it expands to allow the passage of fetal head. Next up is the uterus. It's a pear-shaped muscular organ, 7.5 into 5 into 2.5 centimeters in non-pregnant state. It is divided into fundus. Fundus is the dome-shaped upper part, the body, corpus, central part, the isthmus, narrow portion above the cervix, and and last part is the cervix. It projects into the vagina. Cervix has an internal and an external os, which are the openings to the cervix. The wall of uterus has 3 layers: perimetrium, myometrium and endometrium. Perimetrium is the outer serosa. Myometrium is the smooth muscle layer. These are the strongest muscles found in the human body. And next up is the endometrium. Endometrium is the glandular layer. It changes in menstrual cycle. Endometrium has got 2 parts, stratum basale and stratum functionale. Stratum basale is the constant one, and stratum functionale sheds off at each menstrual cycle and is formed again in the next cycle. Okay, now third one are the fallopian tubes, also called as uterine tubes. They are 10 centimeters in length. The parts from lateral to medial are infundibulum, ampulla, isthmus and intramural or interstitial part. Ampulla is the site of fertilization. This fallopian tube is lined by ciliated columnar epithelium. The next and important part is the ovary. Ovaries are almond shaped, 3 into 2 into 1 centimeter in size. They are covered by germinal epithelium, which is the cuboidal epithelium. The ovary is divided into cortex, which contains follicles, and medulla, which contains blood vessels and nerves. Now coming on to supports of uterus. Uterus has 2 kinds of supports. 2 supports are the primary supports and the secondary supports. Two supports are the pelvic diaphragm or levator ani muscle, the urogenital diaphragm, and the perineal body. These constitute the primary supports of uterus. The secondary or accessory supports are the ligaments. First being the cardinal or the McIndott's ligament, main supporter from cervix to pelvic wall. The uterosacral ligaments from cervix to sacrum. The round ligament of uterus, it keeps the uterus anteverted, and the pubocervical ligaments. All these constitute the secondary supports of uterus. Now the vascular supply of the female reproductive tract. Uterus is supplied by uterine artery, which is a branch of internal iliac artery. Ovaries are supplied by ovarian artery, which is a direct branch of the descending abdominal aorta. And vagina is supplied by the vaginal artery, which is a branch of internal iliac artery. Now the lymphatic drainage. Uterus is drained by external iliac, internal iliac, sacral and para-aortic lymph nodes. Ovary are drained by para-aortic lymph nodes. Vagina is drained in two parts. Upper third is drained by internal iliac lymph nodes, and lower third is drained by superficial inguinal lymph nodes. Now coming on to the nerve supply of the reproductive tract. Uterus is supplied by hypogastric plexus, sympathetic, pelvic, splanchnic, parasympathetic. Pain fibers from the uterus travel via T10 to L1. That is why the labor pain radiates to back or abdomen. When we will see the true labor and the false labor pain, we will say that the false labor pain is localized to an area, while the true labor pain radiates from the anterior side to the posterior side, or comes from the back to the front. Either way, it is the true labor pain. Okay, so this completes our first important topic, which was about the female reproductive tract. Now let us cover the second important topic, which is fundamentals of reproduction. So in this topic, we basically cover the gametogenesis and the fertilization part. Gametogenesis. Spermatogenesis occurs in testes in males. It is a continuous process that occurs in human males from puberty. Spermatogonia convert into spermatocytes, spermatocytes mature into spermatids, and spermatids finally mature into the mobile spermatozoa. This process takes around 64 days. In female, the process of gametogenesis is called oogenesis. It starts in fetal life. When a female is born, there are primary oocytes arrested in prophase 1 until puberty. At ovulation, these primary oocytes get converted into secondary oocyte but arrested in metaphase 1. And when at the time of fertilization, this oocyte will cover the meiosis second. Okay, next up is the hypothalamic pituitary ovarian axis. Hypothalamus releases GnRH in a pulsatile fashion, and due to this effect of gonadotropin releasing hormone, the anterior pituitary secretes FSH and LH. FSH stimulates follicle development and estrogen secretion, while LH triggers ovulation, corpus luteum formation, and progesterone secretion. Now coming to the menstrual cycle phases, they are split into the follicular or proliferative phase and the luteal or secretory phase. The follicular phase lasts from day 1 to 14. The secretion of FSH from anterior pituitary stimulates follicle growth, and the developing follicle from the theca cells secretes estrogen. This estrogen is responsible for the endometrial proliferation. The day of ovulation is day 14. On day 14, there is LH surge. This causes the release of an oocyte, and the body temperature increases by 0.5 degrees Celsius. Next up is the luteal or secretory phase. This occurs between 15 to 28 days, in which corpus luteum secretes progesterone. Endometrial secretory changes are there. And if there is no fertilization, the corpus luteum degenerates and the menstruation begins. Okay, so there is follicular phase, ovulation, and the luteal phase. Next up being the fertilization. Fertilization occurs in the ampulla of fallopian tube. Sperm undergo capacitation and acrosome reaction. Oocyte second. At the time of penetration by the sperm, the oocyte second completes meiosis second. The zygote there is the formation of a zygote. Zygote is again diploid. The zygote grows into morula. Morula develops to form a blastocyst, and this blastocyst gets implanted on day 6 to 7. Okay, this then implantation and early development, blastocyst adheres to the endometrium decidua. Most commonly, the implantation takes part in the fundus part, and or else in the lateral body of the uterus. If other than uterus, the fertilization or the implantation is occurring at some other site, then it will be called ectopic pregnancy. Now this blastocyst has got trophoblast cells. The trophoblast cells differentiate into cytotrophoblast and syncytiotrophoblast. These syncytiotrophoblast cells invade the endometrium, and these are responsible for secreting the human chorionic gonadotropin, and this is the hormone which is detected in urine for urine pregnancy test, and this also is responsible for maintenance of corpus luteum. Okay, so what are the hormonal milestones which a female achieves when she gets pregnant? HCG is detectable in urine or blood by day 8 to 10 post ovulation, and this is responsible for maintenance of corpus luteum till the placenta takes over, which is around 10 to 12 weeks. Estrogen and progesterone rise progressively through pregnancy, and the placental origin of these hormones comes later. Now, the role of corpus luteum. Corpus luteum maintains early pregnancy. It secretes progesterone, which is the main hormone for pregnancy maintenance. If removed before 10 weeks, this can cause miscarriage unless progesterone is supplemented. Okay, so a basic summary of the hormonal roles. GnRH stimulates FSH and LH release from pituitary. FSH is responsible for follicular development. LH is responsible for ovulation and luteinization. Estrogen is responsible for endometrial proliferation, secondary sexual characteristics. Progesterone is responsible for endometrial secretory changes and pregnancy maintenance. HCG is responsible for maintenance of corpus luteum, and this is also used as a pregnancy test hormone. Okay, so this completes our second part, which was about the fundamentals of reproduction. Let us come on to the third topic, which is the placenta and the fetal membranes. The placenta is a temporary organ that develops during pregnancy. This connects fetus to mother for nutrition, gas exchange, and waste elimination. The fetal membranes include amnion, chorion, yolk sac, and allantois. These are essential for protection and fetal development. Now, the development of placenta. Placenta has got two parts, the fetal part and the maternal part. The fetal part develops from chorionic frondosum, which is a combinational development from trophoblast and extraembryonic mesoderm. The maternal part is formed from decidua basalis, which is the modified endometrium of the uterus. Now, this as we have already discussed, the growing fetus has got trophoblast cells, which forms two layers: cytotrophoblast, the inner cell layer, and syncytiotrophoblast, the outer cell layer. This is the layer that invades endometrium and secretes HCG. Now, what does a mature placenta look like? There are characteristic words for placenta. Okay, so it's a disc-like, so-called discoid, has 20 centimeter diameter and 2 to 3 centimeter thick, and almost 500 grams in weight. Okay, the fetal surface of the placenta is smooth, covered by amnion, and shows umbilical cord attachment. The maternal surface is rough with 15 to 20 cotyledons. Now, the circulation, fetal circulation, there are umbilical arteries which open into the chorionic villi, and the exchange of blood happens, and exchange of nutrients, exchange of gases happens, and then the blood is supplied back to the umbilical vein. And now, what about the maternal circulation? Likewise, in the pulmonary artery and veins, where the pulmonary vein carries oxygenated blood, here also umbilical vein carries the oxygenated blood to the fetus, while umbilical arteries are carrying the deoxygenated or the impure blood. Now, what about the maternal circulation? Maternal uterine artery gives branch to spiral arteries. These spiral arteries enter into the intervillous space, and these are drained by endometrial veins. And this intervillous space is the site where the exchange of nutrients or the gases is happening. Now, what are the functions of placenta? First being the respiration. Oxygen from the mother is supplied to the fetus and CO2 is given back. Nutrition, glucose, amino acids and fatty acids are supplied to the fetus. Excretion of urea and creatinine is also done through the placenta. And placenta is very important structure which secretes some hormones. First being the HCG, which maintains corpus luteum. HPL, human placental lactogen, which is responsible for insulin antagonism. And estrogens and progesterone are also secreted, which maintain pregnancy in the later stage. The placenta also has some immunological function which protects the fetus from maternal immune response. Now the placental barrier or the membrane. So what are the structures that separate the maternal and fetal blood? There are cytotrophoblast, syncytotrophoblast, fetal connective tissue and endothelium of the fetal capillaries. So all these form the barrier between maternal and fetal blood. They become thinner as the pregnancy advances. Now some abnormalities of the placenta. They can be placenta previa, in which the implantation of the fetus occurs near the cervix, which will lead to heavy bleeding at the time of delivery. There can be placenta accreta, in which the invasion by syncytotrophoblast cells is great. That is why there is abnormal adherence to the myometrium of the and between the placenta. There can be placental abruption, in which premature separation of placenta can result into this. There will be bleeding and fetal distress. Now finally concluding with fetal membranes, there are 4 membranes. Amnion, amnion is the inner membrane and secretes amniotic fluid. Chorion is the outer membrane and forms the fetal part of placenta. Yolk sac is the agent for early nutrition and is also the first site where hematopoiesis starts in the fetus. And allantois is involved in early blood vessel formation. Later it forms a part of the umbilical cord. Now amniotic fluid. This amniotic fluid is produced by fetal urine, amnion and maternal fluids. What are the functions? First being it serves as a liquid cushion to the fetus. It allows movement by the fetus. It maintains the temperature and prevents adhesions. The normal value of amniotic fluid is 800 to 1000 milliliters at term. What can be the abnormalities regarding amniotic fluid? There can be oligohydroamnios less than 500 ml. This occurs in renal agenesis and can result in IUGR, intrauterine growth retardation. Polyhydroamnios, like when the amniotic fluid is more than 2000 ml. It can occur in anencephaly, esophageal atresia and maternal diabetes. Okay, so this completes our third topic, which was about the placenta and the fetal membranes. Now coming on to the fetus, the physiology and circulation of the fetus. So the growth of fetus is divided into 3 trimesters. In the first trimester occurs the organogenesis. So this is the part which is most susceptible to teratogens. And this is where vitamin B12 supply is essential. Otherwise, the fetus can develop neural tube defects. Okay, in the second trimester, क्या होता है? Rapid growth and differentiation of the organs is there. And in third trimester, there is weight gain and maturation of the organs. How do we measure this? The growth of fetus? We measure the crown to rump length, CRL. This is the best indicator of gestational age in the first trimester. Fetal weight at term is around 3 to 3.5 kgs. Now fetal circulation. Key differences from adult circulation are there in fetus. Oxygenated blood comes from the placenta and not the lungs. And there are 3 shunts which bypass certain organs. There is ductus venosus, which due to which the umbilical vein opens into inferior vena cava and bypasses the liver. There is foramen ovale, due to which right atrium and left atrium are connected to each other. So this bypasses the lungs. And there is ductus arteriosus, in which pulmonary artery opens into aorta. And this also bypasses the lungs because lungs are not functional in the intrauterine life. They become functional once the fetus is delivered and he gasps. That is when the lungs are stretched. And there we know the involvement of lecithin, which is a surfactant. Okay, so that all is there. Now in blood flow path, oxygenated blood from placenta comes to the umbilical veins, and then this umbilical vein then connects to ductus venosus. Through ductus venosus, there is bypassing of the liver, and this enters the inferior vena cava. From inferior vena cava, this enters the right atrium. From the right atrium, it enters through foramen ovale to the left atrium and to the left ventricle, then to the aorta, and aorta supplies it to the brain and upper body. Now the deoxygenated blood from superior vena cava goes to right atrium, to right ventricle, to pulmonary artery, and this again, due to the shunting between them, enters from the ductus arteriosus to the descending aorta, then goes to umbilical arteries, and then to the placenta. Okay, so as we have already said, the umbilical vein carries oxygenated while the umbilical artery carries the deoxygenated blood. Now fetal lung physiology. Lungs are non-functional for gas exchange, filled with fluid, not air. Surfactant produced by type 2 pneumocytes is key for lung maturity, and this increases after 28 weeks and comes to adequate levels at 34 to 36 weeks. This is mostly composed of lecithin, and L to S ratio more than 2 indicates, lungs to surface ratio more than 2 indicates the maturity of lungs. And this is a prime concern in premature deliveries. Okay, so they have the deliveries before 28 weeks or around 28 to 30 weeks, there are more chances of development of acute respiratory distress. Now fetal hemoglobin, as we know, fetal hemoglobin has four chains, 2 alpha and 2 gamma chains rather than 2 beta. This fetal hemoglobin has higher oxygen affinity than adult hemoglobin. This ensures that the oxygen is uptaken from the maternal blood and is sent to the fetal blood, and this is gradually replaced by adult hemoglobin after birth. Now the endocrine functions, fetal adrenal glands produce DHEAS, which is the precursor of placental estrogen. Fetal pancreas produce insulin by 10 to 12 weeks, and if the mother has diabetes, and it can result in fetal hyperinsulinemia, and this hyperinsulinemic fetus will result in macrosomia and neonatal hypoglycemia. Now some points about fetal nutrition. Glucose is the primary energy source transported by facilitated diffusion. Amino acids, lipids, electrolytes and vitamins are transferred via active or passive mechanisms across the placenta. Fetal waste elimination, CO2, urea, creatinine, bilirubin, these all are transferred into maternal circulation via the placenta. And thermoregulation is there. Fetus relies on maternal temperature, has brown fat for postnatal non-shivering thermogenesis. In the infant stage, there is presence of brown fat rather than white fat. So this brown fat is responsible for non-shivering thermogenesis in the early infant life. Now the hormonal control of fetal growth is there. Insulin, IGF-1, thyroid hormones and cortisol, these play a major role. Cortisol also helps in lung maturity, hepatic enzyme induction and surfactant production. Now what are the clinical points regarding this? IUGR, intrauterine growth restriction, is caused by placental insufficiency, infections, hypertension, and macrosomia is there due to maternal diabetes. When the fetus has developed good weight, they are like heavy babies which are delivered. Okay, now coming to the fifth topic and the last topic for this video is about the diagnosis of pregnancy. It's a very important part. There are some presumptive signs. These are experienced by the woman herself or maybe by her relatives. These are not definite, but yeah, presumptive in this society. There is amenorrhea. The first most common initial sign the female experiences is the absence of menstrual flow for maybe 1 or 2 or 3 months. There can be nausea and vomiting, morning sickness. There can be breast changes, tenderness, enlargement and pigmentation of breast is there. She also experiences fatigue, urinary frequency and quickening. What is quickening? Quickening is the perception of fetal movement by mother. In primary gravida females, it occurs like when the female gets pregnant for the first time. It occurs around 18 to 20 weeks. And in multigravida, she knows from her previous experience that what a fetal movement feels like. So she can identify them almost around the age of 16 weeks. Now, there are some probable clinical signs. They're like abdominal enlargement. There can be uterine changes. There are signs like Hagar sign, which is the softening of the lower uterine segment in 6 to 8 weeks. There's Godel sign, which is the softening of cervix from 4 weeks. There's Chadwick sign, which is the bluish discoloration of vaginal mucosa in 6 to 8 weeks. And there can be Palmer sign, which is the regular uterine contraction felt on the bimanual examination. Okay, now positive pregnancy test is there because of HCG detection in urine or blood. Now, what are the final positive, definitive, confirmative signs? There are fetal heart sounds. By Doppler, if we hear, it's around 10 to 12 weeks that we can hear the fetal heart sounds. And by fetoscope, we can hear by 18 to 20 weeks. Fetal movements felt by the examiner, and ultrasound evidence in which gestational sac is visible by 4 to 5 weeks, and fetal pole and cardiac activity from USG is visible by 5.5 to 6 weeks. Now there are some biochemical tests as we have already discussed. HCG detection. HCG is secreted from the syncytiotrophoblasts cells. It appears 8 to 9 days post fertilization, peaks at 8 to 10 weeks, and declines after 12 weeks. This is detected in urine as a qualitative test, in blood, beta HCG as a quantitative test, and this confirms and dates the pregnancy. Okay, now false positives, HCG producing tumors, recent miscarriages, or fertility treatment. In these cases also, HCG test can come out to be positive. Now, imaging ultrasound, the ultrasound imaging can be transvaginal and also transabdominal as well. Okay, so the transvaginal USG is more sensitive in early pregnancy. Over the timeline, gestational sac is visible by 4 to 5 weeks, yolk sac by 5 weeks, fetal pole plus cardiac activity by 5.5 to 6 weeks, and CRL, crown to rump length, is the most accurate for dating the first trimester. Okay, now estimating the gestational age, it is done by Nageli's formula. The expected date of delivery is calculated by adding 9 months and 7 days to the first day of last menstrual cycle experienced by the female. Also, for gestational age in the first trimester, the best method is crown rump length. What can be the other diagnostic tools? There can be pelvic examination done to assess uterine size and consistency. Also, in advanced pregnancy, fundal height is an important marker by which we can almost identify what the age of pregnancy is. Okay, so by 12 weeks, the fundus is just above symphysis pubis. At almost 20 weeks, it reaches the level of umbilicus, and till 36 weeks, it reaches Xiphi sternum. After 36 weeks, when there is engagement of the fetal head, there is a slight drop in the fundus height. So that is what is called as lightening, and this is a welcoming sign in pregnancy that yes, the delivery will happen soon. Okay, so this is what all this diagnosis of pregnancy was. So there can be 3 kinds of signs: presumptive, probable, and positive. So the presumptive sign is subjective, felt by the women, like amenorrhea, quickening. There can be probable signs like Godel, Chadwick, HCG test, and there can be finally conclusive signs like USG, fetal heart, fetal movement. Okay, so this completes our very nice discussion about some high topics in obstetrics. In the next coming videos, we'll be covering the antenatal care, preconceptual counseling, antenatal history and examination part. Okay, so if you like the video, please do comment down, like, share, subscribe. Thanks for watching.